to the end, we'll begin. So good afternoon. Welcome to today's wonderful Wednesday, the fascicles in the EKG in our critical patients, the third in the three-part series of bundle branch block. So just as a quick reminder, we do have to review because it's been quite a while since we've been together. I'm so glad we're together today. Just to remind you about the coronary circulation, that the left anterior descending coronary artery supplies the left main bundle, the main electrical bundle, before bifurcation to the anterior fascicle and the posterior fascicle. LAD supplies the left main bundle and the left anterior fascicle. The posterior circulation, which typically is two methods of circulation, the RCA and the left circumflex, supplies the posterior division of the left bundle branch. So quickly, we take a quick look at our conduction system review, remembering we begin at the sinus node, conducted through the intra-atrial conduction pathways, gathered in the AV junction, transferred into the common bundle, and then we have a left main bundle that splits into the anterior fascicle and the posterior fascicle, as well as the right bundle. Now, the right bundle has a single blood supply, and that would be the LAD, sorry. The left anterior fascicle has a single blood supply, and that would be the LAD. The posterior fascicle has a dual blood supply, and that's typically some divisions coming off of the circumflex as well as the posterior descending artery, which typically comes off of the right coronary artery. So in terms of blood flow dynamic, the most at risk are the right bundle and the left anterior fascicle, and we see alterations in right bundle branch conduction and left anterior fascicular conduction frequently when we see someone who has an LAD lesion. Typically, the more proximal, the more the right bundle and left anterior fascicle will be involved. So that's a really important concept for us to appreciate. The posterior fascicle itself is more structurally sound, and it is also the wonderful beneficiary of a dual blood supply. So the posterior fascicle is the workhorse of our left ventricle, and it is the bundle that is the least affected. So again, left anterior descending supplies the left anterior fascicle as well as the right bundle. So what we often will see is a bifasicular block that will be loss of the right bundle and the left anterior fascicle, relying only on the posterior division of the left bundle to activate our ventricle. So want to make sure that we always talk about the vectors. The vectors are the visualization, or actually not even the visualization, the primary conduction directions. Averaging the vectors together, so you have instantaneous vectors, there are millions. You have mean vectors, there's basically three: to the right, to the left apex, and to the left base. Those are the mean vectors, and those vectors are added together to give us direction of current known as axis. So in general, the average directional current is to the left. The left ventricle is more massive, it requires more electrical conduction, and the primary direction, average direction of electrical current in the heart is to the left, which means on our left-sided leads, that would be lead 1. And our foot lead, which would be AVF, when we're looking at an EKG, you will be upright in lead 1 and upright in AVF. Upright in lead 1 representing the left, upright in AVF representing the right. If they are both upright, that's a normal axis. What we don't often think about is the fact that the instantaneous and average vectors for the left ventricle are both anterior, the front of the heart, and posterior. And when both are active, they cancel out the weight of the other. And that, of course, gives us an average looking vector perspective, which we're going to visualize today in our limb leads. So that's what our focus is for today in our discussion. Want to remind you, first, you've got to understand axis. You choose two leads to represent axis. Just quick look. Lead 1 representing current to the left should always be upright. AVF, representing current going towards the left leg, should always be upright. And we are only in normal axis in both of these when they are both upright. But when you have fascicular changes, your current is going to change, your axis is going to change, because remember, anterior and posterior cancel each other out. But when one stands out more than the other, you will have an axis deviation. You also will have an axis deviation when you have a full bundle branch block. If you have a right bundle branch block, your axis should deviate to the right because current goes more to the right, cell by cell by cell depolarization. And if you have a left bundle branch block, you will typically have a left axis deviation because primary current taking a long time, going to the left, going to the left, going to the left, and taking a long time. You also will see an axis deviation when you have a myocardial infarction. So we've had a lot of discussion about this over the past few sessions, but just as a reminder, when I'm looking at axis, I'm going to use primarily the limb leads. I'm going to use the chest leads for something else, but I'm going to use the limb leads, and I expect to see an upright R wave in lead 1 and an upright R wave in AVF. And when they are both upright, that is a normal axis. So you can see that here. I have a nice normal axis. So now if I take a look at a 12-lead EKG, I can see I'm upright in 1 and I'm upright in AVF. That gives me a nice normal axis. So first and foremost, I'm looking at direction. Do I have a normal axis? Is current primarily going to the left? Now, when I look at axis, I'm primarily looking at the limb leads. But when I look at the chest leads, I'm going to do something called R-wave progression, which means I should see very little current to the right side of the heart, and that's going to be represented by V1 and V2, and those teeny tiny R waves, and more current going towards the left side of the heart, which means my R wave gets bigger, 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 or bigger, bigger, big is what I usually say. And typically R wave is going to be bigger than the downward wave, that would be your S, in V3 or in V4, and that's known as zone of transition. So when I'm quickly looking at an EKG, the first thing I do is a quick look on axis, up and up, normal axis, and V1 through V6, looking at the progression of the R wave, starts small, gets bigger, and should take normal amount of time. Time is measured by the width. So I'm looking at direction and I'm looking at time. The width of my total QRS should be less than 0.11. Anything wider than 0.11 signifies that I have a conduction delay. So that's what I'm going to be in search of. What's causing my conduction delay? When I have one. This EKG does not have one. So, okay. Now here, all I'm seeing here are the limb leads. So if I'm looking at axis, I can see in my limb lead upright in 1, pointing to the left, but downwards in F. So pointing away from the foot. So upright in 1, downwards in F means current is going to the left, but away from the foot. And this is a left axis deviation. Now, I don't have the chest leads here, but what I can also remark on just by looking at these limb leads is that I have a left axis deviation, and it's taking an extraordinary amount of time, greater than 0.12, for full ventricular activation completion. So this is about 3.5 to 4 boxes. So it's 0.14 to 0.16. That's abnormal. So I have a left axis with a wide QRS. Current is going towards the left, but it's taking a lot of time. That's a left axis deviation. And that's a really important thing for us to remember. Now, when we look at intraventricular conduction blocks, we talk about right bundle, we talk about left bundle, we talk about incomplete blocks, and incomplete really lends itself to one small fascicle, the left anterior or the left posterior fascicle being non-conducting and therefore changing the activation direction, but not actually prolonging time. So activation direction is going to change, but not time. And this can be very confounding for people who aren't that interested in cardiology, or you're in the ER looking at an EKG and you're seeing some changes that are worrisome to you. And if you don't really have great skills, and it takes a long time to acquire it, and we practice, and always have to be sure that we're going to be wrong about 50% of the time, no matter how great we are, we're going to be wrong. Even the greatest cardiologists should admit to you they're going to be wrong sometimes about how they evaluate the EKG. So the idea here is practice, and practice. You see something interesting, you look at it, you tell me, you send the image to me, you tell me what you think it is, and I'll tell you if I agree. Doesn't mean I'm right, doesn't mean you're right, just means that we either agree or we disagree. But you got to practice, and you know what? You have to do it every single day. Okay, so let's remember with right bundle branch block, impulses travel normally through the left ventricle, but then have to go cell by cell by cell to depolarize the right ventricle. That means the major current now is shifted to, it's my right, so your left, my right, shifting to the right, taking longer than 3 boxes, 120 milliseconds, and on my right-sided leads, I'm going to see that direction is going to the right. So that would be on my limb leads, AVR, on my AVF. And on my chest leads, that'll be V1 and V2, may even be V3, all current going to the right, meaning upright, in AVR, completely abnormal. In AVF, very normal. In V1 and V2, big uprights in V1 and V2, totally abnormal. And in my left-sided leads, so that would be 1L, V5, and V6, I have a deep and usually wide. So wide is more important than deep, and S wave. Now remember, I normally conducted the left ventricle, so I'm going to have an R wave in leads 1, AVL, V5, and 6, followed by a wide S wave below the baseline, an S wave that is wide. So very important, and always vitally and profoundly important to remember, vital, that the ST segment and the T waves in the leads looking at the bundle branch block. So that, in this case, right bundle branch will be your right-sided leads, primarily AVR, V1, and V2. Your ST segments and your T waves will go in the opposite direction of the QRS. So the QRS is upright, the ST and the T are downwards. That is abnormal. ST should always be flat. T wave should always go in the same direction as the R wave. So this is called discordance. And the discordance is appropriate when we're talking about a right bundle branch block. So 3 questions, and really 4 questions, okay? Axis, width, direction in V1 and V6, and ST-T wave changes in leads that are looking at bundle branch block. So primarily, I'm going to look at my axis, okay? Primarily, I'm upright in 1, and in AVF, I am primarily downwards. That's a left axis deviation, okay? It's upright in 1 and downwards in F. Already, I know it's a left axis deviation. And then I'm going to look at the width of the QRS. Now, I want to mention here that what you're seeing, where all those arrows are, this is a rate-related bundle branch block. A rate-related right bundle branch block. So intermittently, I'm going to see this R wave with the deep S wave, and then I don't see it. And I see it over here in V1, an R wave with an ST and T wave that is going in the opposite direction. This is a right bundle branch block, but it's related to the patient's heart rate. So it comes and it goes. Sometimes people say, oh, he's switching bundles. No, he's not switching bundles. He's normal and he's abnormal. And this often happens when patients' heart rates are just a little bit higher because the right bundle takes time to repolarize. But in addition to that, I have something very unexpected. So we'll come back to this a little bit later, or we'll talk about it in other ways, is that when you have a right bundle, when you have normal function, you should have a normal axis, upright in 1, upright in F. When you have a right bundle branch block, normally you're going to see more downwards in 1 and more upright in F, indicating a right axis deviation. So by the way, with a pure right bundle branch block, you always expect a right axis deviation. But I don't have that here. I have a left axis deviation. So right away I say, I've got a rate-related right bundle branch block, but I have a left axis deviation. Something is wrong. Something is wrong. And what's going to be wrong here is either you have an old MI or you have a right bundle branch block with a left anterior fascicular block. So I'm a little ahead of myself. I'm so sorry because I would never want to do that, but we'll come back to this a little later. With our right bundle branch block, that fourth clue, when I see that right bundle branch block, I expect to see the ST segment sloping downwards and the T wave in the opposite direction. So this is called discordance. And I expect discordance whenever I have a right bundle branch block. Okay, if I look at V5 and V6, you can see I have an R wave here, which indicates current to the left, but then I have a really deep S wave. So I have quite a few issues that are going on here as I'm looking at that EKG. Now with left bundle branch block, the normal direction is to the left ventricle. So that's all normal, but it's going to take a really long time to depolarize. And the fact is that I've already depolarized and contracted the right ventricle by the time I depolarize and contract the left ventricle. So I now have dysynchronous, whenever you have a bundle branch block, dysynchronous depolarization and dysynchronous contraction. With the left bundle branch block, the right ventricle depolarizes and contracts first. The left ventricle depolarizes and contracts second. And it's a prolonged second because it takes a lot of time to pass that electrical stimulation through cell by cell to the left ventricle. So again, your QRS duration is greater than 120 milliseconds, and you're going to have a very wide-looking R wave in your left-sided leads. Lead 1, AVL, positive electrode over here on the left, V5 and V6, positive electrodes on the left chest. Those are all left-sided leads. And on my right-sided leads, I'm going to have a wide, deep S wave, or I may just have a QS wave, no R wave at all. So this is very, very important. And again, we're going to have those secondary abnormalities. In my left-sided leads, I'm going to have a downsloping ST with an inverted T wave. That's called discordance. Those are the criteria. It's pretty straightforward. Is your direction normal? Yes or no? Is your time normal? Yes or no? And do you have discordant ST T waves? Pretty darn straightforward. Now that's what we see in right and left bundle branch block. So let's just take a quick look at that application here. So in V1, you can see you have that wide deep S. You may have a QS, and it may be not. Sure, you may just have a straight QS. And in your left-sided lead, and that'll be V6, I might have an R prime, meaning two little R waves with a little notch, or just a wide deep R, a really wide tall R, or an equally notched R. So there's lots of configurations that can take place, but the key here is current is going to the left, it takes a lot of time, and my T wave and ST segment are actually discordant. T wave should always go in the direction of the QRS. Okay, so that's a really important thing for us to think about and look at when we're evaluating our patients. So again, I'm going to take a look at this patient, upright in 1, downwards in F, I have a left axis. Okay, now I'm looking for why I have a left axis. Okay, now first of all, right away I can say, oh, that looks kind of wide. It's about 0.16. Oh, and my ST is downsloping with an inverted T. I think this is a left bundle branch block. I'm going to confirm it when I look at my chest leads, starting with V1 and correlating that to V6. V1 has a tiny R and a deep S. Okay, well, all right. But more importantly, in V5 and V6, I have an upright R wave, but it takes a lot of time, and I have discordant ST-T waves. Now, the discordance of the ST and T wave are only in the leads that are really looking at the side where the bundle is blocked. So lead 1, AVL, V5, V6, all severe left-sided leads, all have ST downslope, T wave, inverted in a discordant pattern. I don't expect discordance anywhere else, and I don't have it. Now, the one caveat to this is in V1 and V2, I always expect to see ST segment and ST segment flat and the T wave upright. But in left bundle branch block, what you are going to see is your T waves get a little bit bigger because they're opposite of the left bundle branch block leads, and your ST segments are typically a little bit elevated. And you want to remind yourself that the number one reason for false activation of a STEMI is left bundle branch block. Because with left bundle branch block, you get this ST segment elevation, V1, V2, sometimes in V3, with these big peak T waves. And if you're not knowledgeable about an EKG, you would say, oh, the patient's having an anterior septal MI, it's got ST segment elevation. And about 90% of false activation of STEMI is left bundle branch block. Okay, so here we take another one, okay? Upright in 1, pointing to the left, downwards in AVF, so I've got a left axis. And by the way, when I was looking at my axis, I noted that my R wave is extraordinarily wide, my ST is sloped downwards, and my T wave is inverted. I've got also something else here called the U wave. That's not our purpose today. So I say, oh, I better look quickly at my other left-sided lead AVL, and then I'm going to look quickly at V5 and V6, and I see that I do have a wide R wave here, but there are some other abnormalities that concern me. But ST segments are downslope, T wave is inverted. This is a left axis with a left bundle branch block because of the width and because of the direction. So axis is measured direction in the limb leads, and bundle branch block looks really at the direction in V1 versus V6. Current away from the right and towards the left. Okay. So just as a review, remember in left bundle branch block in lead 1 and V6, I expect a wide R wave with downsloping ST and inverted T waves. And the right-sided lead is going to represent that current is going away from that right-sided lead and taking a lot of time. With a right bundle branch block for me is really easy for me to diagnose because I never expect to have a really large R wave in V1. So V1 is where I'm always going to look for a right bundle branch block, and I'm going to have a big R wave. I might have a right rabbit ear, I might have a left rabbit ear, I might not have a rabbit ear at all, but current is going towards the right side, which means in the right-sided leads, it will be upright, and it takes a lot of time. ST segment slopes down, T wave is inverted. And what I see in my left-sided lead, 1, 6, L, and V5, is that I have this significant S wave. Following the R, I have that deep or wide S wave. So that's going to be really important when I'm trying to evaluate and correlate that. So remember those associated features, really, really, really important, is that ST segments and T waves are going to go in that opposite direction to the main direction of the QRS complex in bundle branch block. And we have poor R wave progression, meaning it's not small, bigger, bigger, big, big. It's huge, smaller, smaller, big, big, big. So not progressing, not starting small and getting bigger. That's poor progression. And absence of current really until about V3 or V4 is poor progression as well. So I'm always going to look at that R wave progression, and then I'm going to look at axis deviation. Now, I want to bring us to something that is really relatively straightforward, but I think really vital for people who are aspiring to become more expert in the evaluation of the EKG. I want to remind you that the LAD supplies the anterior left bundle. LAD supplies the anterior left bundle, and the LAD and the RCA give some supply to the posterior bundle, but the LAD, the septal LAD supplies your right bundle. So I want to remind you, the LAD in general is responsible for the anterior fascicle of the left bundle, as well as the right bundle. And so depending on where occlusion to blood flow has occurred, you may see on first presentation with your patient a right bundle branch block with a left anterior fascicular block. That is the most common bifascicular block that we ever see. So we always want to remember those fascicles. So again, in definition, looking here, you see the LAF and the LPF, left anterior, left posterior. And of course, we're not looking at a 3D model, but in a 3D model, anterior fascicle in the front of the left heart, posterior fascicle in the back of the left heart. Left anterior fascicular block occurs when the impulse is delayed in the transmission through the left anterior fascicle. Now that's going to change my axis, but it isn't going to cause a widened QRS. That's so important. Left posterior fascicular block occurs when conduction across the left posterior fascicle is delayed or interrupted. That's going to change my axis, but it's not going to increase my width of my QRS. It is going to give me some very particular signals, which we're now going to take a quick look at. In order to attempt to show you in a 3D model, here is your anterior fascicle, here is your posterior fascicle. And when those are both activated, basically at the same time, they cancel out the direct visualization of one fascicle versus the other. But when one fascicle is blocked, what we're going to see is the current activation from the other fascicle. So the anterior fascicle actually electrically activates the heart from anterior towards posterior, starts at the anterior, goes to the posterior. That's what this is designed to show you. And the posterior fascicle starts at the posterior and moves to the anterior. So when they are both occurring, the visualization of them independently is canceled. If I have an anterior fascicular block, what I'm going to actually visualize is posterior activation, which is first approaching the anterior chest. So my anterior leads are, and that would be really my left side leads, so 1 and AVL are going to have a little R wave. And then they're going to have a deep S wave. So it's going to be a very important perspective. So let's look at a left anterior fascicular block, also referred to as hemiblock. That's not really the correct term. We really prefer left anterior fascicular block. Okay, so our anterior, so the heart, this is the heart as it's facing upwards, and the anterior division has been blocked. So I'm not going to see that current. What I'm going to see is current beginning at the posterior surface and then circling around the left ventricle. So you can see here, my left anterior fascicle is blocked. My posterior fascicle is going to be now in charge of the heart. Now that's going to give me a very significant visualization. So don't get yourself too worried here. We're going to look at this only in the limb leads, okay? So if the posterior fascicle is in charge, so this is the anterior fascicle in charge. So let's go over here. If the posterior fascicle is in charge, what I'm going to see is in my left-sided leads, AVL and lead 1, I'm going to have a small R wave as current comes towards those leads. That's the posterior fascicle activating the heart. A small R wave followed by a deep S. That's going to give me an axis deviation. And in my foot leads, 2, 3, and AVF, I'm going to have a small Q wave. Okay, that small Q wave is the mirror image of that small R wave. So don't get yourself upset here. All it is you're looking at the current when it's unopposed. Posterior fascicle is activating the heart. Posterior fascicle activates the heart towards the superior and therefore inferior, which then gives me first a Q wave and then an R wave in my foot leads, 2, 3, and AVF, a small R and a deep S in 1 and AVL, and this will be called a right axis deviation. So I'm going to see with an anterior fascicular block, with a posterior fascicular block, with an anterior fascicular. Wait, let me just think. No, with a posterior fascicular block, what I'm going to see is a significant right axis deviation. So remember, if pure right bundle branch block and with a posterior fascicular block, I'm going to have a right axis deviation. If I have a posterior fascicular block, the anterior fascicle is in charge of the heart. And what's going to be really, really important here is that now I'm going to see the exact opposite. Remember, the two together canceled each other out. So I'm going to see the exact opposite. So in my extreme left leads and the limb leads, 1 in AVL, I'm going to have a small Q and a large R wave. And in 2, 3 in AVF, I'm going to have a small R and a large S. So you should never see this in normal activation. Never should you see this independent activation. So if LAF is blocked, you have a left anterior fascicle blocked, you have only one fascicle on the left bundle, and that would be the left posterior. So again, I'm going to expect to see in my left-sided leads a small Q and a big R, and in my right-sided or inferior leads, I'm going to see a small R and a deep S. If my posterior is blocked, you just have one activation for the left ventricle. That's going to give me a right axis deviation, okay? I'm going to have a small R, oops, sorry. I have a small R in my left-sided leads, 1 in AVL with a deep S, and a small Q in my leg leads, AVF, leads 2 and 3, small Q and big R. Now you're thinking, oh my God, this is way too much for me to be thinking about, but it actually really isn't, because if you understand EKG and you've been attending EKG, you'll remember that normally you have small Q waves in 1 and L, but you do not have Q waves in 2, 3 and AVF. In 2, 3 and AVF, you always expect a big R wave. You never expect a small R wave. So those are the things you're going to remember as you're looking at the EKG. So with left anterior fascicular block, your QRS complex, it might be wider than 0.10, but it's not going to be wider than 0.12. So it might be 0.11. You may have a little bit of a delay. With an LAFB, you will have a left axis deviation. Okay, so if I have a left axis deviation, I haven't had an anterior MI or an anteroseptal MI, I just have a left axis deviation, and I don't have a left bundle branch block. Most frequently, that's going to be because you have a left anterior fascicular block. That means you actually have a bundle branch block. It's just one fascicle. Okay, so in leads 1 in AVL, small Q, big R. In 2, 3 in AVF, small R, deep S. A small Q and a big R is not that unusual in leads 1 in AVL. A small R and a deep S is completely unusual in leads 2, 3, and AVF. Okay. Now, peak action time is also really important, but that's beyond what we need to discuss here. Okay, so we're looking at our limb leads. First and foremost, look for axis, upright in 1, downwards in F. This is a right axis. The next thing I'm going to look at with the right axis is I want to look at the direction in my limb lead is the direction to the right, which means it would be upright in AVR, and it is not. And by the way, my QRS is not wide. So now I'm going to look for my next criteria. I have a left axis deviation pointing towards lead 1 and away from the foot. I've got a left axis deviation. Do I have a small Q followed by a big R? Yes, I do. And then I look at, I can just choose AVF, lead 3 or lead 2, it doesn't matter, but I'm going to choose AVF. I have a tiny R with a big S wave. That tells me this is a left anterior fascicular block, LAFB. Left axis and mirror images in my left side lead 1 in AVL to my right side or foot leads 2, 3 in AVF. Pretty straightforward as you look at it. So let's look at this patient then. Again, big upright R, downwards in AVF, left axis, small Q wave, big R in lead 1, small R wave, deep S in lead 3, lead 2. AVF doesn't have to be in all 3 of the leads, just needs to be in one lead representing that lead group. I have a left anterior fascicular block, and I have a left axis deviation. So 1 and AVL are upright, 2, 3, and AVF are primarily negative. I have a left axis deviation and an LAFB. Now, LAFB may not be that unusual. LAFB with right bundle branch block, really worrisome, because I've lost 2 fascicles of my conduction system, and that often happens when I have an acute enteroseptal MI. So again, depending on where the lesion is in the LAD, I may see that as a primary presentation. I can also see it in patients who have cardiomyopathy or have profound hypertensive heart disease. But if the patient has had an old inferior wall MI, and a lot of times the computer is going to mix this up and say, this is an old MI. But I want to make sure that we appreciate that what we're looking at is those Q waves, those small Q waves in 2, 3, and AVF as an old inferior MI, and that's going to be really, really important. Left anterior fascicular block is very common, and we see it a lot. So when you have an unexplained left axis deviation, look for left anterior fascicular block. Less common is the posterior fascicular block. Again, the duration of the QRS is normal. It's less than 120 milliseconds, 3 boxes. It may be a little bit wider than 0.10, which is normal, so you might be at 0.11. And you have a right axis deviation. You have an RS complex in leads 1 and AVL, a small upright, and then a deep downwards, and then prominent Q waves in leads 2, 3, and AVF. Now, this is going to, again, be quite confusing. And so I think I actually posted that one in the wrong space. It's going to be quite confusing as it correlates to an old inferior MI. So again, now I have a blocked posterior division. I'm activating towards the anterior surface, so anterior and up to the left, and then down to the inferior wall. Okay, so that's what's going to give us our visualization. So I'm looking at this EKG. There is no doubt in my mind something's wrong with this EKG. Okay, primarily downwards in lead 1, primarily upright in AVF. This is the right axis deviation. Now, the first thing I think about with right axis deviation is right bundle branch block. I only have my limb leads here, but with right bundle branch block, current goes to the right. So I'd expect a big upright in AVR, which I don't have. Okay, and my QRS is not wide. Now, I really would like to have my chest leads as well, but I don't have them here. So this is all I have to look at. And now what I'm going to look at is I'm looking for a mirror image, meaning if I have a small R and a deeper S in 1 in AVL, I'm expecting a small Q and a big R in 2, 3, and or AVF, which I indeed do. Now, I don't always have a Q wave because that might be really small, but I can indeed find a Q wave in 3, and I can find a Q wave in AVF, followed by a big R. Okay, I don't have SD segment abnormality. I don't have T wave discordance. All I have is I am visualizing the independent vectors of activation from either the posterior fascicle or the anterior fascicle, and that is never normal. That's it. So again, we talk a lot when we're looking at EKGs, we talk a lot about peak time of activation because you expect activation to be almost straight up and no delay to peak time, which is the peak of the R wave. And you can see here, you've got just a little slope. That's unusual. And that's a delayed activation time, which also is part of fascicular block. Now, left posterior fascicular block does have some significance. Again, remember, it might mimic an old inferior wall MI because of the Q waves in 2, 3, and AVF, but isolated left posterior fascicular block is very rare because not only does it have blood supply from left-sided circulation, it also has blood supply from right-sided circulation. So it has a dual blood supply. The posterior fascicle itself is much sturdier than the anterior fascicle. So your width of your anterior fascicle and the width of your posterior fascicle are very different. And the posterior fascicle is much sturdier and much less prone to injury. So again, we go back to what we looked at before and reminding ourselves when the anterior fascicle is blocked, you activate from the posterior. And what that means is you're going to do superior and later inferior activation, giving me small Q and big R. And when we're talking about a block of the posterior fascicle, the direction of activation is initially inferior, giving me that small R wave and 2, 3 and AVF, and then goes superior, which then gives me that deep S wave. So first and foremost, I'm always looking at the trio of my foot leads, 2, 3, and AVF, for an abnormality when I have an axis deviation. If I'm seeing independent vectors, remember, those should be basically balanced out, and I shouldn't be seeing particularly, I should not see a small R wave in 2, 3, and AVF, followed by a deep S, or I should not see a small Q wave followed by a big R. Those are the things that I'm looking for when I'm evaluating fascicular blocks. So remember what we talked about before, okay? And now we take a quick look at this patient. So downwards in 1, upright in F, that's a right axis deviation. I have small r and a big S in 1 and an AVL, and a small q and a big R in basically in 2, 3, and AVF. Don't really see a Q wave in 2. That's not going to cause me a problem because I see a small Q here and a small Q here. And it's really small. You have to look for it. It's not going to jump out at you. And a lot of times your computer is not going to be able to diagnose this. So you really have to evaluate it. Okay, now remember we've got a right axis deviation because upright in 2, 3, and AVF, that's representing the foot leads, also representing the right side of the heart, and downwards in 1 and AVL, downwards. So I don't like to use the words negative because that gets confused with the poles of your EKG. Now, to end with, a really common issue when 2 of 3 fascicles are blocked. So most commonly, when we're talking about fascicles, most commonly it's right bundle and left anterior fascicle. That occurs most commonly with coronary artery disease in the anterior, the LAD, the left main. Of course, that's not going to be your worry. When you got a left main, you're probably not going to survive unless we get it open quick. But with a left main, with a left anterior division, left anterior descending coronary artery occlusion, and particularly proximal to the division of the left main to the LAD, that's going to involve the septal wall. We see it also with hypertension. We can see it with aortic stenosis, and we can see it in congenital heart disease. So let's take a look at what we've learned. Okay, I'm looking first at my limb leads, and I'm going to say 1 is not primarily upright, has a lot of downward. It's almost equiphasic, but it's not primarily upright. And AVF is primarily downwards. So at least I have some upright in lead 1. This is a left axis. Okay, now the next thing I'm going to say is I'm going to look for a wide QRS. And I think I have a wide QRS in my limb leads. I'm not going to make any diagnosis from my limb leads, but it does look like I have a little bit of a wide QRS in 2 and an AVF. But I'm not going to make a diagnosis here. I'm going to look at AVR. AVR should never be upright, but here it is. So then I jump over to my chest leads, starting with V1. Current is going to the right, to the right, to the right, and it's taking a lot of time, going to the right, and my ST segment slope downwards and my T wave is inverted. This is a right bundle branch block. Now I want to remind you, with a pure right bundle branch block, you always, always, always expect a right axis deviation. But here, I don't have a right axis deviation. So I have a right bundle branch block with a left axis deviation. So the very first thing I'm going to think about is, do I have a left anterior fascicular block? Okay. Now, in this lead, it doesn't 100% match, but when I look at lead 1, I see a little Q, and I look at AVL, I see a little Q, followed by a pretty big R wave. I have that deep S wave, that's from the right bundle branch block, but I have a small Q and a big R in 1 and AVL. And when I look at leads 2, 3, and AVF, I have a small R followed by a deep S. Now, why is this important to me? Because if I have a patient who is having ongoing chest discomfort, who's evolving a STEMI, they have only 1 fascicle left, and that's their posterior fascicle. They block 2 fascicles, so complete block to the right bundle, and a loss of left anterior fascicle, only the posterior fascicle remains intact. So I, as a bedside nurse, are going to be acutely aware of this. I don't need to call everybody in about it. Cardiology has already looked at it. They probably already know. Your providers may or may not know much about fascicular block. And it'd be important to say this looks like a bifascicular block. I'm worried because my patient now has only the posterior fascicle, but you have something else that's also really important here. And that is you have a prolonged PR interval. So your PR interval is prolonged, and that is concerning because it's telling me that I may have some conduction slowing also through the posterior fascicle. So I have a prolonged PR interval, I have a left anterior fascicular block, and I have a right bundle branch block. I've got a patient who's at risk, and me as the bedside nurse, I'm going to kind of be all over this patient until either we have reperfused them or until they are past their acute and critical state. I'm going to be all over them like a fly on a Cheeto. I'm going to be sure I know how to operate the external pacemaker. I'm going to be sure that everybody knows that it's a small possibility, but it is a possibility. And if that patient arrests, it's probably not going to be a VTAC arrest. It's probably going to be an asystolic arrest, which means pacing. And if they're not a post-cardiac surgical patient, pacing and epinephrine are going to be the mainstay of resuscitation, as well as CPR. So really important to remember, left anterior fascicular block is much more common than left posterior fascicular block, traditionally because the anterior fascicle is really narrow, it's really long, it's thin, it's prone to damage easily, it's exposed to the anterior ejection forces, that's called the left ventricular transit time, the opening of the aortic valve and all that stress as there's an outflow, that's the outflow tract, left ventricular outflow tract or transit time, which actually is very stressful and it stresses the anterior fascicle, but most importantly, only one blood supply. So in about 4% of acute myocardial infarction, you are going to see an LAFB. It is the most common intraventricular conduction deficit whenever you have an acute anterior MI, and you may not have a right bundle branch block. You may only have a left anterior fascicular block. It can also be seen with patients who have an acute inferior wall MI, but more commonly, you're going to see it with an anterior MI. Now, I'm going to just mention to you here that some of you have heard me talk about this before, but I was a consultant at Piedmont. I wasn't on staff there. I was really a faculty member there for the development of their sepsis protocol. And all physicians and nurses in the hospital had to attend a sepsis course with me over a couple of weeks' time. And so everybody, almost everybody attended. And I got to know a lot of people, lots of nurses, but also a lot of physicians. And with my husband, who was having obstructive sleep apnea, some shortness of breath, a lot of lethargy, no chest pain. He hadn't seen a primary care physician for a long time. And I connected to one of the physicians there who I thought was going to be fantastic for my husband because of his attitude and the way that he managed himself. I felt my husband would be pretty cool with him, and indeed he was. And on the very first physical examination, I went with my husband. I explained some of the things I was worried about in medical lingo. And my husband is an artist, so he was very kind of nervous. And the physician, who is a primary care physician, brings me the EKG and he says, "This EKG, I think it looks pretty good." And I said, well, I would agree with you very basically, but my husband's got a left anterior fascicular block, and I'm really concerned about that. So could we please get a cardiology consultation? So that day, the chief of cardiology saw my husband, did a stress test, and the next day did a cardiac catheterization. My husband had 100% occlusion of his LAD. Now, he had developed collateral circulation, never had any chest pain, but the only reason that I actually asked for him to see a cardiologist was he had a left anterior fascicular block. In our traditional 12-lead EKG classes and cardiac boot camp classes, we perform EKGs on each other. We wear sports bras on that day, and we're all nurses. We've all seen everything, but people might be shy, and that's okay. If you're shy, you don't have to have your EKG. But I have actually diagnosed two nurses, young 40-year-old nurses with left anterior fascicular block, referred them to a cardiologist. Both of them ended up getting stress test and cardiac cath. Both of them ended up with stents. So that may be a good thing or a bad thing from your point of view. Maybe you don't ever want to have a stent, or you don't want to know if you have coronary disease. But these were individuals, my husband in particular, was an individual who was likely to have a complete occlusion and an anterior MI, which he did not do. And that was because we were observant. And also because I had a great relationship with the physician who listened to what I had to say and then asked for a cardiology consult. So it isn't worthless to actually be able to look at an EKG and diagnose these things and be able to talk about them. And to know also that you might think it's an LAFB, and his was just a standalone LAFB, didn't even have a right bundle. But just a standalone LAFB, you might think it, and you talk to your cardiologist and they say, well, no, and here's why. Okay, great. What a great teachable moment. I'm going to learn. I never, ever, ever want to feel like I can't bring forward my perspective, my point of view in a discussion, and I should never be afraid to be wrong, because it's better to be wrong than to have been right and be silent. To be right and to be silent, from my point of view, is the worst thing that can happen to a nurse or a physician or an APP. To be silent because you're afraid that you might be wrong. The worst thing that can ever happen. I'm so grateful for you and so happy that you've attended here today. I hope this has enriched your understanding. It's not the end, it's just the beginning. And it's a journey we take together, and we always are going together on our journeys with virtual learning, just-in-time learning, classwork, NTI, SCCM, whatever meetings you go to. We're always on a journey of learning, and the day your learning stops is the day that you will be no longer functionally cognitive. So we want to achieve learning every single day as much as possible. I'm so grateful to you. I'm grateful to you for joining today. And I'm going to sign off for now. I'm going to see you next week. On Tuesday, I'm going to talk about an acute chest and sickle cell anemia. I'm also going to be presenting that in the CVICU. I'm hoping that I'm going to be able to do that on Thursday, but if the forecast is bad, I might not stay late. So we will do that in virtual next Tuesday, and we will also do it next Tuesday evening in the CVICU, because we currently have a patient with sickle cell and an acute chest. So I'll do sickle cell and acute chest on Tuesday and another cardiac program next Wednesday. I invite you to join. I thank you very much for caring about your patients, caring about your knowledge, and being willing always to challenge yourself. Thank you so very, very much.